This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers.
Hair's looking good, Juz.
Right? Thank you. It's just the right amount of fluff. Didn't come right out of the shower. I should have saved after the episode. Do it again. You are. I didn't realize you pressed record. That's hilarious. Oh my God. Thank you. Yes, I know. Because I am
Juz's hair is looking very special today.
Luscious. You know, if you're not on YouTube, you're missing out on today's episode because I'm not late, like just rushing out of the shower. I'm here. Sorry. 5 minutes. All right. So besides my luscious hair, Dan's here too, just less hair.
My hair looks good.
His hair looks good. His eyebrows always look really good. I will say that. Yeah, Dan, your eyebrow game is strong. Okay. Jokes aside, today we're going to get into a really, really great example that expands upon what we talked about last time with regards to metabolic drivers to central sensitization and various markers that you can look for and common comorbid conditions with central sensitization. And one of the biggest ones that I see all the time, deal with personally, and Dan sees a ton of in his practice, especially compared to other physicians, is hEDS or EDS, so hypermobile spectrum disorder, Ehlers-Danlos disorder, those types of things. And it's one of the main, like I said, comorbid diseases that come before technically often central sensitization, but come with it. And so it's also a really great example because it ties into the lifestyle piece of things and helps you see how some of these behavioral pieces to things that we do impact do have a disproportionate effect, especially in this setting, on things that then develop downstream. And we'll get into some interesting questions around, is it preventable? Is it not preventable? Is it progressive? You know, and really break it apart and help you guys see, especially from Dan's perspective, having teased this out in a really helpful way, what the different pieces are, why they're happening. Similarly as with central sensitization, right? There's different buckets, there's sort of umbrellas within each one. And when you can see each piece of it and what's driving what and how the different pieces fit together, it gives you a much better ability to actually sort it out.
All righty. I suppose just quickly, Ehlers-Danlos syndrome. Ehlers-Danlos syndrome is a collection of 13 different diagnoses. So there's EDS 1 through 13. EDS, all except for type 3 are a known genetic abnormality. And hypermobile EDS, which is type 3, doesn't have a known genetic abnormality. And so I think that we want to sort of start from that sort of point. And the most common one is by far type 3, which is hypermobile EDS. And there's specific diagnostic criteria. And if you don't meet the diagnostic criteria, but you're a bit flexible, but you don't have don't tick all the boxes, you fit into hypermobile spectrum disorder. I think we're talking about semantics rather than it being particularly important. But
and HSD can be very symptomatic too.
Oh my God, yes.
So that's where it doesn't matter, yes, technically, but it's not related to how bad it can be.
So what I wanted to do first is sort of maybe just talk about how I came to hypermobile.
How did we get here? Why are we doing this episode?
Why do I know? Why do I have a thought process around this these days? So, okay. So one of my friends and mentors, Bruce Mitchell, was sort of like the main pain guy. He's a sports physician as well. He was my director of training at one point in time. And he was a main pain guy that saw patients within sort of the Melbourne region with hypermobile EDS. And so there's a group of doctors through Melbourne that we all know each other. We all share patients. And he was doing essentially the musculoskeletal side and a chunk of the pain component. And Bruce retired.
Dan Bruce.
And said,
"Here,
go see Dan."
An onslaught of
and that was
HEDS.
I swear he was just like, go see Dan. And I was like, okay. And so I got inundated with hypermobile EDS patients.
It's like a tsunami of
hypermobility. And just to put it into some sort of context, they are the most complex patients I have ever looked after, like ever.
We're pretty special.
But one of the things that happens within, when you get overwhelmed with something is you start to see patterns that you wouldn't normally see before.
Right.
So when you see somebody that is, when you see a hEDS patient, like once every, once every couple of weeks or once every, couple of months, they don't, like the patterns, you can't see the patterns.
There's not enough touch points to see the patterns. It's like with me, when I started only with CRPS patients, that's why I too, in that setting, could see the patterns developing because it was over and over and over again, similar population.
And so what became really apparent was that, if you do the math on it, the likelihood that somebody has 10 different diagnoses, the math on that is pretty much like minute. And the likelihood that you've got 100 people that have the same 10 diagnoses and they all have like the likelihood of that not being one disease process is pretty much zero. So there had to be an underlying process that was driving all of it. And so
common to everyone.
And I got to the point where I was really frustrated with how everything was put together piecemeal. So everyone was like, manage their, I was essentially within the team within Melbourne. Like I ended up I get assigned with managing the musculoskeletal bits. And then, then the other guys are managing the cardiovascular bits and other people are managing the, bits of the neurology, and others are doing the gastrointestinal stuff, and others are doing the MCAS stuff. And
each piece is outsourced to its own specialist.
Each piece is getting outsourced, and I was like, oh my God, this, and everyone collects 10 or so specialists, and
which is also hard and overwhelming from a patient perspective. From a clinician perspective, then you also can't see the patterns if it's all broken apart.
So that's when I started to think about, well, how does this actually all fit together? Like, how did you come? Like, you're obviously seeing it from the CRPS side. What were you saying?
Well, that's what's funny is that CRPS is such an intense, dominant, extremely excruciating pathology that it is what sort of gets all the attention. But what I started seeing over and over again in so many CRPS patients I worked with is that a very high percentage of them were also hypermobile or had hEDS or EDS and these different, multitude of varieties, typically those most common ones. And so, CRPS isn't perfectly defined, but I think we can kind of all agree on it having a strong autoimmune component. It's not that CRPS patients have hEDS. It's more that hEDS patients have or then develop CRPS. And like me, you may not have even known that you had hEDS prior, but the CRPS piece is actually what develops later down the line when something else triggers that, probably more in the autoimmune bucket of stuff under hypermobility, which Dan will get into in his different buckets. And so again, there's no way that CRPS patients just happen to also have hEDS very commonly. One has to be fitting with the other. And I think that's the way that it should be switched from a perspective point of view, rather than, just happen to have the same thing. And then POTS, and then dysautonomia, and then, these other pieces of hypermobility CRPS patients also have. So that's what's kind of funny is Dan and I working separately before we had even come together from different perspectives and working with different populations, we're also seeing the similar patterns develop and why. And again, it makes no sense. You don't have 27 different diagnoses just by coinkydink.
Yeah, that doesn't happen. That's not a thing.
So it's not possible.
All right. So what I want to say at the outset is that the rest of this podcast is not the way that the Ehlers-Danlos Syndrome Society sees EDS at the moment. I think that they do recognize that a lot of the things that we're about to talk about play a role, but the science is really early. And the science probably isn't at a point where, they as an organization would, roll in behind it and go, yep, this is definitely the way it works. That said, I sit at the pointy end. And for me, I've needed a structure around how to approach these patients. And so this is my structure, sort of backed by various bits of science, paper and common sense. But the EDS guys aren't with us on this yet. That's okay.
Yeah.
They'll work it out soon.
Yeah. And that's part of what creates that disjointed, point of view. And that's one of the better books out there. If you're looking at it from the traditional perspective, is that book Disjointed? But that's a very difficult way to look at it as a patient and manage it.
Yeah.
So
to try and work it out, I started the process of, okay, all the EDSs except for hypermobile EDS have got a genetic abnormality. So that genetic abnormality effectively means you have a gene abnormality that results in a wonky piece of connective tissue that results in you being, in some form stretchy.
Right.
If it's vascular EDS, guess what? Your arteries are stretchy. If it's classical EDS, it's more, skin, musculoskeletal stuff. But hypermobile EDS has, to this date, no defined genetic abnormality. And so that then for me goes, okay, well, it's not a genetic abnormality. It has to be a metabolic abnormality.
What else? Yeah.
So what else can it be? And when you look at metabolic abnormalities, what can it be? So it's not a carbohydrate disorder. So that's your diabetes and diabetes management stuff.
Right.
It's not a fat management disorder. So this has to be a protein metabolism disorder, right? And so if you then take the next step from there, it has to be, if it's a protein metabolism disorder, it has to be one of three things. It has to be not synthesizing enough protein, breaking down too much protein, or it's both.
Right. You get too little and you break it down too fast.
Yeah. And so in that setting, I just went, okay, let's start with what breaks down connective tissue. There's a set of enzymes that are called matrix metalloproteinases that are the enzymes that break down most collagen and extracellular matrix. And so what I started to do is I just play my little nerd game on PubMed, where I just started to look for what are, looking at the associated diseases, and then start to look at matrix metalloproteinases. And if I'm right, then these disease processes should be associated with elevated levels of matrix metalloproteinases. And when you start looking, it's there. Migraines associated with increased levels of MMP2 and MMP9. There's associations with POTS, there's associations with depression, there's associations with anxiety, blah, blah, blah.
Right.
So
yeah, it's not that there's no research that supports this. It's just not some massive, large scale study on hEDS patients where you could sort of present it that way. Yeah.
However, through this process, I found this paper that was, which is, which is a great paper. And this is really what I've sort of leveraged off with these guys. The paper's written by, first author is Marco Ritelli, and the final author is Marina Colombi. And so they're an Italian lab that do a very large amount of hypermobile and other EDS research. And they published a paper in 2022. And it outlines what is their mechanism of hypermobile EDS. And this paper has been not referenced very much since that time. And I think the reason is for this. This is the title. This is the title of the, it's bad marketing. This is the title of the paper. RNA sequence of dermal fibroblasts from patients with hypermobile Ehlers-Danlos syndrome and hypermobile spectrum disorders support their categorization as a single entity and involvement in extracellular matrix degrading and pro-inflammatory pathomechanics.
That's the title, not the first paragraph?
That's the title. I would have retitled this, Hypermobile EDS is a protein metabolism disorder.
Collagen breakdown in hypermobile EDS patients.
Done.
Yeah, end of story.
Okay, so now that paper is available online. Pretty sure you can download it for free.
Yeah, we could chuck it on maybe the website too.
Yeah, we'll chuck it on the website. Yeah. It's really science dense, it is heavy reading. However, in the discussion, they lay down their hypothesis. And so within the hypothesis, they pretty much put together the stats that show that hypermobile EDS comes about due to two things. Due to poor protein synthesis, which they showed through RNA mechanisms, and increased protein breakdown by matrix metalloproteinases.
Yeah, so both sides.
Yeah. What that then does is that ends up doing two things. So with matrix metalloproteinases, you get poor protein synthesis, increased breakdown, and you get two outcomes. So firstly, you get a mechanical outcome. So that first outcome is you are stretchy. And so what's getting stretchy? So ligaments are stretchy. So you have stretchy arms and legs and backs and necks. Your blood vessels become stretchy. So the important thing with stretchy arms and legs is that then goes on to create pain. And so pain, muscle spasm, recurrent dislocations,
lack of stability, poor proprioception,
blah, blah, blah. So the second piece that gets stretchy is blood vessels. So in the blood vessel piece, what is happening there is your venous system, so your veins dilate out, you pull blood in your legs. That results in a decrease in blood supply back to your heart. What ends up happening, your heart rate goes up, you get lightheaded, you get dizzy. And then erroneously, that gets labeled as POTS. Now, that's actually postural hypotension. And that's what it is in the early phases. In the later phases, it becomes true POTS, where you get a racing heart rate with minimal change in blood pressure. But early, when you're getting a drop in the blood pressure, that's actually postural hypertension, and your heart rate going up is normal.
It's a normal response to your blood vessel stretching, not a separate disorder. So you can see how already you got a diagnosis when it's just a manifestation of the initial.
Now, the conservative measures for managing that are the same as POTS. So it kind of works out, but nonetheless, they're not the same thing.
Technically, yeah.
The other thing that takes place is then you get stretching in the gastrointestinal tract. And so with stretching the gastrointestinal tract, what ends up happening is that's when you go on to get your gastroparesis. You get reflux because you can't close sphincters, so everything's going back the wrong way. And the other thing that's happening is particularly your large bowels dilating, and you get significant amounts of constipation. People will wax and wane between constipation and diarrhea, and it's very likely that diarrhea is not like bowels getting completely flushed out. It's probably overflow diarrhea, where you're constipated, and the way your body then responds at times is you get diarrhea and you get overflow. So you remain constipated, but the diarrhea flows around it, and then you got your watery stool.
Well, and this is where then you get the bloating, the nausea, a lot of the, difficult, if stuff can't come out, stuff can't go in. And this too is so many CRPS patients with gastroparesis, difficulty getting enough protein, which again, not a coincidence. It's not a separate thing. Yeah.
Okay. And so that's the first piece. And there's two major parts. So we've already talked about that first bit. You get the mechanical component, and then you get this second component. When you break down collagen, into little pieces. And these pieces are called DAMPs. So danger associated molecular patterns. Now, the easiest way to think about this is that if you cut yourself, what you've done is you've cut a whole stack of collagen and you expose little ends of the collagen. And those little ends are DAMPs. And there's lots of versions of DAMPs that come from breakdown of cells and blah, blah, blah. But this is the version that's coming from, breaking of collagen. Okay. And when you expose those ends of the collagen, what it does, it triggers off your nervous system to trigger off an inflammatory response, which then leads to healing of the cut, which then leads to, yay, we're all better.
Yay.
Okay.
Except we're not talking about a cut.
However, what's probably happening with hypermobile EDS patients is that they are breaking down collagen into little pieces all the time, and you're getting this widespread, persistent, low-grade inflammatory process.
Because your body's like, what is this? I don't recognize this.
Yeah. And it's like, danger.
Yeah. Whoop, whoop, whoop.
Yeah. And so
it's almost like pain is an alarm signal. It's the weirdest thing.
Who would have thought? And so what ends up happening there is that's when you get three main cells that get involved. Okay. And so the first cell is mast cell. The second cells are T and probably B cells, which are autoimmune cells. And then our last component is a set of cells called microglia. If we go through each one of those, what happens with the immune system? And someone's probably going to call and give me a schooling on this. But anyway, let's just go with this.
We'll have them on an episode once.
Yeah, they can come on and tell me how I'm wrong. But what happens with the immune system? The immune system is always monitoring for abnormal sort of things to come into the environment. Okay. And it does that by like picking up certain things called antigens or like chemicals, and it binds to antibodies at the same time. But the upshot is that it will bind to something and it then looks for other signals that say danger. Okay. So the DAMPs don't necessarily directly cause activation of these mast cells. But what ends up happening is the mast cell picks something up
Right.
And it's surrounded by damps because they're getting broken down by these enzymes all the time. And so you start getting inappropriate activation of mast cells.
Right.
And so mast cells start pinging off to things that they shouldn't ping off to because they pick something up and normally they go, oh, no danger. But in the setting of hypermobile EDS patients, you're breaking down all the collagen, the danger signal is there. And then the cell goes, ooh, odd thing plus danger cell, that must be a problem. Boom.
Generate
and then pain. We start to go on to develop our mast cell activation syndromes.
Right.
And that's where people start getting weird anaphylaxis out of nowhere.
Yeah.
They start getting weird
sensitivity,
hives,
allergy,
weird sedity, blah, blah, blah. That just comes out of nowhere.
Skin flushing. Yeah.
Yeah. And they tend to have a relatively atopic background. So they'll have a history of asthma, they have a history of eczema, they have a history of other
skin conditions
that fit into the background of mast cell activation. The next sort of cell is then T and B cells, and those cells are involved with autoimmune diseases, and sort of they behave in the same way. They look for abnormal antigens or things that are from outside the body. They look for associated danger signals. If the danger signal is there plus something's abnormal, boom, away you go. And when you start getting exposed to certain damps and certain drivers, you then come up with certain, autoimmune diseases. Right. And the most common autoimmune disease that I think we see in hypermobile EDS patients is psoriasis, particularly psoriatic arthritis or spondyloarthritis, which is one of the autoimmune diseases affecting the spine. And so that's where damps are then driving the autoimmune component to it.
Right.
And then the last piece is damps get picked up by microglia. Okay, so microglia and astrocytes are the support cells to your nervous system. They sit in effectively two states, a state that is anti-inflammatory, which are type 2, and then type 2 microglia, and a state that are pro-inflammatory. This information comes out of the concussion data. And basically what happens is that damps are picked up by microglia and they are polarized. So when you go from being type 1 to type 2 or type 2 to type 1, basically they go from type 2, which is anti-inflammatory, and they are polarized to become type 1. They become pro-inflammatory. And so in that setting, now what you've got is you've got the nervous system that is sitting in a inflammatory soup.
Right.
And now you've got your central sensitization.
Right.
And so
a bunch of danger signals going out in the context of inflammation.
Yeah. So in that setting now, what we've got is your 7 buckets of central sensitization. So we've now got an inflammatory process that's causing sensory hypersensitivity. So you get increases in pain sensitivity. So if it's widespread, we label you with fibromyalgia. If it's focal, we label you with your focal pain disorders, temporal mandibular joint pain, etc. And then everyone gets hypersensitive to light, sound, smell, touch, taste, heat,
other sensory
cold,
inputs,
food intolerance, and balance problems.
Yep.
You get the next bucket, which is sleep disturbance. The bucket after that is then cognitive dysfunction. The bit after that is mood disturbance. So you get labeled with your anxiety and depression. You then get your dysautonomias. So this is where you get true POTS. And in this setting, what's happening is you're probably getting a neuroinflammatory process that involves the brainstem. And so that's when you're getting true heart rates going up, blood pressure staying stable.
Right, that autonomic dysfunction.
And so then you've got your abnormal sweating, your gastrointestinal system. So now you've got IBS, your bladder symptoms. So increased frequency, urgency, incomplete emptying.
Neurogenic bladder fits under.
I don't know. Does neurogenic bladder fit into that diet thing? I don't know if it does.
It's hard to say.
I don't think it does.
It's just because it's common with CRPS patients too, which makes me think of it.
If your fatigue component of your brain's involved, now you've got chronic fatigue syndrome. Yeah. And if the motor system is involved, you're getting restless leg syndrome, tremor, cramping, myotonic jerks, so jerking in your arms and legs all over the shop. And then when you're really bad, you get non-epileptic seizures. So I've got a bunch of those patients. And so in that setting, then what we've done was we've created a structure for how you can think about this disease process, not being 27
different diseases, right?
It's one diagnosis. It's one process that drives across multiple systems. For me, that's where I get to. I sort of get to the point where I'm thinking, okay, what do we got? And because people come to me for the pain bit, okay,
Right.
I'm primarily looking at which bit do you want that hurts? Do you want me to fix? Okay, we'll start working on that. But what else is driving? What's your major driver? Is MCAS the major driver? Is the autoimmune stuff the major driver?
It's GIT.
Is it GIT the major driver? And then you start with that stuff. And
it's just like with sensitization. What's the dominant bucket, or what's the dominant, biggest bang for your buck, most impactful?
Yeah. The thing that's a little bit different for me than the way I'm thinking about this now is that I'm looking at it from a mechanistic perspective. It's not, previously I would have thought further down the pathway. So I would have been thinking about the sensory hypersensitivity, the brain fog,
you start with the sensitization.
So but we're starting down at, you're really anxious, we'll treat the anxiety.
Totally.
Where
actually
what I'm now thinking about is like, well, you're stretchy, it's probably a protein metabolism disorder. Well, let's treat that. And first, you've dominantly got MCAS symptoms. Great. Let's start with treating that. And so we're starting at a mechanistic level rather than starting at down the bottom.
Well, again, you're starting at the input. You're starting at the inputs rather than the outputs.
Yeah. So,
and it doesn't mean you don't have to manage the outputs or address them, but if you don't break down the inputs and what's driving it, that's the limiting factor.
There's a couple of important things within this discussion, and I'll get your thoughts on this as well, is that it's a genetic predisposition, right? Just because you've got the genes doesn't mean you get the disorder. Okay, so
it's like anything else, nature, and you have your predisposition, but what adds to that?
But it means you've got to get exposed to something else. And so I kind of think of it like type 1 diabetes, okay? Type 1 diabetes is a genetic predisposition. You've got to get exposed to a couple of other things before you get to the disease process, right? I think that hypermobile EDS is probably the same. And I think there's probably 3 or 4 things that you get exposed to over time that then drive the process. And so the first one is EBV. So Epstein-Barr virus or glandular fever, how it's involved is what it does is it increases the production of matrix metalloproteinases. So what you've got is that you're cruising along, coping very well. You're a great athlete because you are a bit more flexible than everybody else.
You got some extra range of motion.
You got some extra range of motion. Everything's going great. You have glandular fever, also known as kissing disease. So you kiss the wrong person.
Whoa, Dan, I take offense to that. I had mono. I had mono in high school. That's what. Same.
Yeah.
Just trucking it along.
Just
crushing basketball.
The wrong people.
Just kissing the wrong people.
You get your EBV, and then all of a sudden you get the increased production of MMPs, and you get this stretching out. So you stretch that a little bit further. You get your drop in your blood pressure, and then you start getting these low-grade activation of your mast cells of bite, and so you fall off the perch.
So now you're more symptomatic.
Yeah, now you're more symptomatic. The other things that people get exposed to, and a set of antibiotics called fluoroquinolones. So fluoroquinolones, the most common one we use is ciprofloxacin. Other ones are norfloxacin, and there's another floxacin. What we use them for is we use them for ear infections, urinary tract infections, and traveler's diarrhea. And what they do is they have a very well-known complication of tendon disorders. So you can get particularly Achilles tendonitis after taking ciprofloxacin. But the way it does that is by increasing
the stretchy
MMP production. And so as a result, you get increased MMP production. For normal people, that results in Achilles tendinopathy. For people with, an underlying predisposition to hEDS, that just drives the whole underlying disease process. And if you get online, you can find a whole bunch of fluoroquinolone help groups that have all got, from my perspective, the way I read it, so they've all got hEDS, and they took the fluoroquinolones and everything went off. And so, I think that's the mechanism there. I think the other 2 mechanisms, one is major trauma, whether it be emotional or physical. And so you'll see a lot of patients. I've got a patient that I quite like that ended up having an operation, quite traumatic during U12 period, was to manage a malignancy. and developed all these other weird symptoms afterwards that, is essentially linked to this trauma event and this driving of a sensitization.
Right.
And the last thing that really drives it is then the disease process itself, because it affects your stomach and your ability to digest stuff. It gets harder to digest a bunch of cows.
Yeah, and to eat enough protein.
Yeah. So everyone goes, oh, it's so hard to digest cows now. I'm going to stop eating cows and chickens. And as a result, the resulting effect is you get less protein in.
Right.
You've got ongoing protein
You're already
breakdown.
breaking it down too fast. Right.
Yeah. And so, everyone goes vegan or vegetarian and they just get worse for a period of time. It's like,
yeah. Well, and honestly, the other thing is how many people, even without really intense gut stuff, don't even come close to the amount of protein that you should eat. Most women are walking around eating like 50, I'm not kidding, and I don't even mean people who are unwell, like 50, 60 grams of protein maybe a day, which is not even half of what most should be eating. So again, if you don't have hEDS, okay, you just will have less muscle mass and that's the end of it. And down the line, that's not great. But if you have hEDS and you have these other components, you do not have any margin for error. And so that always jumps off the page when I start with people too is, oh my God, the discrepancy on what you should be eating protein-wise versus what you are, whether or not it's the gut stuff, that's creating an even larger barrier to entry with that because it's significant. Yeah.
This is an interesting discussion from the perspective of, so the recommended daily intake is 0.8 grams per kilogram per day. Okay,
way more
so
than most people realize. Yeah.
That is to just survive, right? If you look at the data recommends 1.2 grams per kilogram per day if you're unwell. Okay, and so you know what? If you're coming to me, you're unwell.
Sorry.
So you need to start at 1.2. Like that's the baseline.
Non-negotiable.
That's the non-negotiable. And if you look at what we do with athletes, if we're looking to get them to bulk, so we're getting them to put on muscle mass at that point in time, you're looking at 1.6 to 2 grams per kilogram per day. And I think that's like really, they're the things that we're seeing. We're seeing, number one, people can't eat and they feel terrible. So they become vegan. So we got no protein in, very, very little.
Yeah.
You get the fact that if you just add your RDIs at 0.8 grams, you're under. Most people, if you listen to the podcast, you are probably unwell and you need to be at 1.2 grams.
You're probably not doing awesome.
Let's be honest. If you have to listen to us, and then if you want to bulk, you got to be at higher.
Yeah, and depending on how active you are too. Again, if most people are not, that's part of the challenge, but you want to get there and have the base of support to do so.
Yes. Make sure you get your protein in.
That's kind of the segue to where do we start?
Yeah. Where do you start with EDS? And where I am starting, putting aside which bit hurts, I'll fix that as a component of what we do.
Right.
It's let's get your protein intake up. And so how do you do that? We already sort of said our target's at least 1.2 grams per kilogram per day.
Yeah.
To do that with food is hard. How do you do it?
Well, it's tricky too, because you have to respect, where your guts are at, and you can't just shove huge amounts, like literally mass wise, not massive amounts, but big amounts of food people can't tolerate. So we've talked about this on the conservative management episode a bit too, but sneaking powders in everywhere you can, in your coffee, in smoothies, in yogurt, even Dan has talked about. So you don't have to eat 2 steaks a day and 12 ounces of chicken and salmon. That's like nauseating to people. So how can you be sneaky about it, right? Look at what snacks you're eating and look at that as an opportunity to always think sort of protein first. You should be getting a protein bar that doesn't have 20 grams of protein is not a protein bar. It's just marketing it as such. That's because if you think about also like what is a protein source? A source of something is not something that has like 5 to 10% of your total daily value of it. That's too small. So that's why peanut butter isn't a protein source. It's a fat source because it has too small of a percentage of what you need in an entire day to really
allow it to be. Spinach.
Spinach.
I eat lots of spinach. Lots of people tell me that they have a high spinach diet. I'm like,
no, you don't.
I get it's got protein in it.
Right. Like this is a disconnect between the total amount you need. Right. So you don't have to eat half a cow to get there, but you have to be smart and intentional and strategic about where can you upgrade from snack perspectives, and same thing with your regular meals. What is your meal composition? Are you lacking a protein source at lunch or dinner? Is your breakfast, I just grab a banana and I go, so you sort of see where are the holes. It's kind of like Tetris, and where can you fill things in and improve it being included to begin with, and then be creative about how do you include it or supplement it in a way that respects how much food and what types of food you can tolerate. And then you just kind of work your way up. So when I work with people, I don't just off the jump increase their protein like 60 grams a day, because that's a bit jarring. So we kind of go in, all right, let's increase it 20 grams at breakfast. 20. And, for each meal, you should probably be trying to get at least 35 grams. Again, because it's a lost opportunity if you don't, because you can only eat so much food. So pick your battles, prioritize what you want to improve first. And once you acclimate and adjust to that improvement, great, pick the next one. So depending on where you're at to begin with, how much you have to go up will vary, but those are sort of the strategies to look for. And when you, for example, if you're having a tortilla, there's tortillas that have like 5 grams of protein versus there's some that have 12 or 14 even. And even those little things do add up, because now with 2 tortillas, it's actually a protein source rather than meh. And so you didn't increase the volume or the bulk of food, but you made a better choice that, again, if you eat that same thing every day, a lot of us are pretty habitual with what we eat. That's that times 7. That's like almost a day's worth of protein with one switch that you've increased over the course of a week. Yeah. So small things do add up, and then you just, build from there.
I like hydrolyzed collagen.
Yeah.
Now, there's the question around, in this population of patients, what's the best protein? The answer is we have no idea. And so as, it's hard for most patients to get reasonable amounts of protein in. I'm just at get the one in that doesn't stir up your guts.
Right.
You tolerate, you don't mind the texture of, et cetera, et cetera, et cetera. And I think one of the things that with hydrolyzed collagen that I like is that it dissolves into nothing. You can't taste it.
Right.
It just dissolves. Having
collagen
coffee.
Is the most
I got patients that get up in the morning, put a teaspoon or 2 of hydrolyzed collagen into their coffee, and away they're there. And so, they're doing that, and it makes it easy.
And there's specific brands that are designed even to dissolve the best in coffee and that type of thing. And so you can easily Google that, right? And find the ones because sometimes the texture doesn't, I can kind of taste it in there. And that's normal. So, but don't give up. Just pick one that's actually designed for that. For example.
I think the other thing that works as well for if you do have, POTS symptoms, so you're getting lightheadedness, dizziness when you stand up and your heart rate's racing, one of the management strategies is increasing your fluid intake.
Yes.
Okay. And so, yes, you're adding salt to that as well in many cases, but chuck in some protein.
Again, dissolves in liquid. It doesn't have to be a smoothie, because that's a lot of,
You've got to, the basis of all POTS management is get your fluid intake up, and you're really aiming at around 3 liters a day.
3 liters, yeah.
Chuck your protein into that. You'll
no
get
different
there.
Than coffee.
Yeah, you'll definitely get there. And don't give up when the first one you buy
sucks.
Tastes terrible.
Weird. Right. And this is what I tell people all the time. Don't give, it's like a relationship. Don't commit to a 3-gallon thing of protein. Buy the packets. And it's not the most cost effective way to consume it, but until you have got a couple, all right, these are my favorite go-tos, try to get them in small, less economical ways. Yeah. You can get them online that way often, and just pay a tiny bit more so that you can test some and not.
Yeah. If you're in Australia, so I have no association with these guys, Bulk Nutrients, bulknutrients.com does sample packs. You can get samples across pretty much all their products.
Is that Aussie only, Dan?
I
think it is. Yeah.
I think so. Yeah. They're a Tasmanian company.
But yeah, similar. Right idea.
If they want to sponsor us, I'd be happy with that.
Yeah. So that's not a bad idea.
Anyway, what I say, just have a look at them, and they do really good quality products. I use them myself.
That's why Dan's guns are the way they are.
Yes, they are. No, my guns are the way they are because of my dad.
Whoa! You got to warn us, Dan. Because of my curls. Just buy stuff in packets to try protein.
Just get a little.
That's it.
Get a little. Yeah. If you're wondering what to buy, one of the best things you can do is look for the boring packet.
Yeah.
So
the less fancy marketing, the better.
Yeah. If the packet has got like some, jacked monster like screaming at you on it, it's probably got a bunch of other stuff in it. So just go through the boring packets, and you can also look for other things that if you're wanting to make sure there isn't any other stuff in it, like look for stuff that's randomly tested. And for all the companies that do random testing, they will market the fact that they do random testing. So that is saying if you can do, more importantly, is even batch testing. And so if you're an athlete, of course, protein powders are probably your biggest risk for inadvertent doping. So make sure that you're looking at either a product that is approved by your sporting body, or you make sure that everything's batch tested, because you will get done, unfortunately. If you're a normal human being, well, just get the boring pack.
All right. Good protein talk.
Yes.
Okay. So do you want to go into an example, like the long COVID example?
Why does long COVID present the same? Long COVID is essentially a central sensitization disorder. And so it presents very similarly to patients with hypermobile EDS.
Who have the sensitization piece going off.
Who have the sensitization piece going on. And so the reason why long COVID presents the same is that it is probably causing a neuroinflammatory process at the brainstem level. And so the areas that are involved with that, there's a reasonable paper published recently on the anatomy of this. That's where you're getting your POTS symptoms. That's where you're getting your chronic fatigue symptoms, because you're getting a neuroinflammatory process all within the same area. And the thing that is different here is the mechanism by which the neuroinflammation is being triggered. So with long COVID, it's the virus and the secondary immune response.
Right. Different reason, but same output.
Hypermobile EDS, it's the breakdown of collagen and the DAMPs that is driving the inflammatory response. But because it's affecting the same anatomical site, in this setting, the brainstem, that's why you get your dysautonomias, your fatigue, your balance disturbance, your hypersensitivities, etc.
With long COVID, you just don't have those other aforementioned buckets that Dan went over at the beginning when it comes to hypermobility. Not the sensitization buckets, but the other, autoimmune, stretchy, etc., glial cells, blah, blah.
The other thing that I think is what can you do, like what do you avoid? There's probably two pieces within this. Number one, or two or three pieces in this. Number one, you want to avoid fluoroquinolones. So antibiotics such as ciprofloxacin, they're not your friends. You need to look at other alternatives. You want to avoid zinc. And I've probably made a whole bunch of people shudder out there. So matrix metalloproteinases are zinc-dependent enzymes. And so where we need a certain amount of zinc to function, once you're taking supplements that have got a ton of zinc, you've already, what you're doing is just supercharging. You're
not helping yourself. You're not helping. Yeah, you got enough.
You got too many enzymes. Just making them work better by making sure you've got plenty of zinc is not the best way to go about. So I encourage people to not use any zinc-based supplements. The question around zinc-based sunscreens, I don't know what the
topical applications are.
Maybe it makes a difference, maybe it doesn't. Who knows?
How much absorbs? Yeah.
I think the next piece is, try not to be vegan.
Don't be vegan. Yeah. Even I was, from a testing perspective, I was vegan for the first year and a half of when I had CRPS, to see if I could affect, how inflamed I basically was in any way. And honestly, I don't think it made a difference. And I had to cook so much to be able to get enough protein, because if you're getting processed, restaurant or even grocery store type of vegan foods, you're not even going to come it's going to be dramatically far off. So it takes so much effort and thought to hit it, and so much work if you're vegan, that in and of itself, for people who are in extreme pain and can't stand and cannot, spend credits dicking around in the kitchen for hours, it's not sustainable. So can it be done? Yes, I kind of did, but it takes so much work. And this was it was the beginning of COVID. I had nothing else that I was doing, and this could take up a large amount of space and energy and effort. But if it's not for real serious moral reasons, try to avoid it, because it just is really, really hard. Can it be done? Yes, but it's a tough position to put yourself in, and it's an uphill battle.
Yeah. So. And look, and I think in this setting, I think don't be vegan's probably a bit rough, particularly if you're there on ethical grounds.
Well, or religious. Like there are situations where it's unavoidable, but yeah.
But at the end of the day, yes, you probably can hit your targets. And so you've then got soy, pea, rice, and some of the synthetics.
Other powder sources.
And that's all good. Like we have no idea which protein is better. And so I just encourage people to get in what you can get in. If you're going to be vegan, that's okay. Your target's still 1.2 grams per kilogram per day.
It's just harder to get there.
It's just a little bit harder to get there. But 1.2.
Yeah.
Get there.
And the other challenge is your body uses less of the plant-based protein sources than animal-based sources. So the same 20 grams is not created equal with animal versus plant. So you actually have to eat even more than your target from a bioavailability perspective to use what your target is a little bit.
Is there an equivalent? That's a really good question. I haven't looked at that. Is there an equivalent dose? Someone will know. If you look at the data with muscle growth, that yes, you're right. They don't match up. You're much better off eating whey. So whey protein's got the the best muscle growth versus everything else. However, can you dose up to get the same effect? I don't know. I have to have a look if there's a study that's been done that 40 grams of whey equals 60 grams of soy. I don't know. So the last thing that I like about this thought process. Okay, so if hypermobile EDS is a protein metabolism disorder and it's progressive. Okay, so what ends up happening, and I suppose I haven't given a timeline. So it's progressive. How it starts as ankle sprains because that's the joint that gets loaded the most.
Again, in high school basketball, always my ankles, always.
Then comes knees because then once again, next most load goes through your knees. And then depending on what your sport is, it's either hips or shoulders. The next high pressure system goes there. So that's your arteries. They start to dilate out. Your veins start to dilate out. You start getting your POTS type syndromes.
Yeah.
For females, because when they start menstruating, they get really painful periods and heavy periods. The reason for that is matrix metalloproteinases break down the inside lining of the uterus. And so they, hEDS patients probably have far more of these enzymes. And as a result, they get heavier periods and more painful periods. Then what takes place is the gastrointestinal system starts to stretch. So that's when you start getting your reflux, your nausea, your bloating, your constipation.
IBS,
The piece after that is that the nervous system sits in a sac. That sac is called the dura. It probably also stretches. And when it stretches, the pressure around the brain goes down. Your brain sinks in your head and it pulls on your meninges, and that gives you headaches. And so
this is where you get the weird neurological stuff.
You start getting weird neurology. And so you lay down, you feel better. You sit up, you feel worse. And so what we do in how we've labeled that in the medical world is like that's a CSF leak, but we could never find the leak.
So if you can't find the leak, right,
maybe it's just not a leak, maybe it's just low pressure. And so for my patients that have been investigated by neurologists and they get a lumbar puncture and they look at the pressure, their pressure is always at the lower end of normal. So it's never below normal, but it's always the low end of normal. And I sort of wonder, as what we're seeing here is we're seeing the stretchiness of the dura that's then giving you your postural headaches, and we're labeling that as CSF leaks. Maybe not. I don't know.
Well, this is where you get the Chiari malformation piece too for some folks. Like I have a patient who has that.
And your brain's sinking.
Sinks.
Within your skull. And so a Chiari malformation is basically where your brain is sinking and the bottom part of it, which is your brainstem, is coming through the big hole at the bottom of your skull. The next thing that takes place from a sequence is then people start to get their mast cell activation syndrome. That starts sort of late teens, early 20s. Then you start to see autoimmune disorders in your early 20s. And, the central sensitization gradually gets worse because even though we sort of spoke about the central sensitization being driven at a microglia level by DAMPs, the pain,
all these other factors accumulate.
The POTS,
yeah,
the gastrointestinal stuff, the mast cell activation, the autoimmune disease, they also all drive the central sensitization component. And so as a result, as you get further down, you then start to get more and more and more of those
more and more
7
sensitization.
buckets.
Yeah.
But that's a 25-year process.
Yep.
And it continues. And so my thought is, well, if you've got a 25-year process, and if it is a protein metabolism disorder,
right? If what all the way on the left is collagen breakdown,
can you prevent the disease process? And so,
is it truly progressive, or is it because of not addressing the driver?
Yeah, or can you address the driver? I think it is truly progressive.
Yeah,
but I think that can you address the driver?
Right.
And I kind of hope that the answer is yes. And this is where, for me, I've started really to go with talking to patients, because I think that the one question is, can you reverse it? That's hard. So yes, you can start loading, people get substantially better.
Yeah.
But if it depends on what fires are burning.
And how far, right? How far down that track are you, like any other disease? Yeah.
You might be able to treat the underlying, driver, get your protein intake up, but you've got your MCAS burning, you've got the autoimmune disease burning, you've got your central sensitization burning.
Yeah, you still have to treat those.
You've got to treat those as, because the bushfire is out of control.
Yeah. Yes.
However, is this a preventable disease? So for those people that go on to have kids, is there a way to actually prevent them going down this track? And so there is like
because you know of the predisposition, and so can you interrupt it earlier instead of being 20 years down the track before you're like, oh shit, I should have been having more protein from jump.
Yes, and this is so the bit that's exciting about this for me is that
it's positive.
We have other examples of this process. So you look at Alzheimer's disease. Okay, so Alzheimer's disease up until recently, everyone was like, you can't prevent it, blah, blah, blah. There's a fantastic researcher over in the US, Richard Isaacson, who went, hang on, this is we know that people can have a predisposition. We know we can look at their genetic abnormalities. We know that we can test them 30 years beforehand, and we can see changes that indicate they're going down the track of developing Alzheimer's. We have a 30-year lead time before they are symptomatic. Can we actually prevent that process? And he's gone through a whole stack of preventative processes, and he's published some really good data. And, if I can't recommend him enough to go have a look at his stuff. He's quite amazing. But is hypermobile EDS the same?
Right.
We know
that thinking
so
process.
How do you know that you've got a genetic predisposition? Well, you've got a mum or a dad that is stretchy and has potentially got the same problems. How do you know at like 10, 20, 30 years before you've got like the full gamut of the disease that you may be predisposed? Well, you're getting like ankle sprains.
Right. You're at the earlier mechanical pieces of it. Yeah.
How might we prevent that process? And that's, high protein diet, 1.2 grams per kilogram per day. When you're dealing with the kids, what do? Like, you got to sneak veggies into their diet. My wife is like the best at sneaking veggies in.
Covert veggie.
And so I'll be looking at something and going, what's
is this a veggie?
It's the veggies have been snuck in.
Conned again.
But it's the same thing. I think does this give us an opportunity to potentially prevent this disease process as it develops? And do I have evidence for that? The answer is no. Do I think that it's possible? Yes. And I think I would like to strive towards it. So
right. And again, when you put together what we just talked through today with kind of common sense, it's not that there's no evidence for this. It's just you have to look at all the pieces. And as a patient, again, although sometimes it's hard to feel that you have this responsibility, I feel it's much better to be able to have agency and impact things and believe you can than to feel like you can't and you have no say and it's just progressive no matter what you do. So if you can kind of put together the experience within a practice, the different pieces of evidence and sort of the common sense that surrounds that, why not try? Why not see where that gets you? And I see the same thing in my patients who dramatically improve and increase protein, right? And other lifestyle factors around that from a nutrition, diet, movement perspective, but especially what you're putting in your mouth and working around and with the barriers to entry with that, they decrease levels of sensitization. And then at least you're impacting what you can, even if you are further down the line, unfortunately.
Yeah, let's finish it up there. I think that I would like to try
With a hopeful
and prove
ending
that this is a preventable disease, so that if you've got it, maybe we can stop your kids getting it, or at least getting the bad bits.
Yeah, just minimize
The bad bits. Maybe the angle is, instead of trying to minimize the bad bits, what do you get if you have a kid that is slightly flexible, is strong?
You're a super athlete. Yeah,
you
that's
athlete.
Actually, it's that's the advantage.
Maybe the pitch isn't actually what you've got to do is you're going to prevent kids getting this. What you're going to do is you're going to generate like super athletes.
Turn them into total studs.
That love winning.
Yeah. Yes.
Maybe not.
Is there a genetic predisposition for that? I think so. Dan and I both have it. Love winning. Must win. All right.
Yes. All right.
Awesome.
Thanks, Charles.
Thanks so much, Dan. That was really helpful. Appreciate it, guys, and we will see you next time. Take care.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.